Welcome. I'm Marie Harvey, and I'm the Associate Dean for Research in the College of Public Health and Human Sciences here at Oregon State University. And I'm delighted that you're joining the seminar today. Adam Branscombe, who's Professor of Biostatistics in the College of Public Health and Human Sciences, has graciously agreed that he will introduce our speaker today and he will moderate the session. He will also provide some more instructions about the format of this seminar. So let's get started, and please join me in welcoming Dr. Branscombe.
Great, thank you, Marie. And thanks to Gretchen and your office for organizing this and all college seminars. And a big welcome and thank you to the audience for joining us for this College of Public Health and Human Sciences research presentation via Zoom. We have muted all of your microphones, so to ask a question, please use the Q&A feature in Zoom, and we will be moderating it and repeating questions for the entire audience today. So I'm delighted to welcome my friend and colleague, Dr. Diego Cuadros. After earning a Ph.D. in biology from the University of Kentucky, Diego was a postdoctoral research associate for the infectious disease epidemiology group at Cornell Medicine in Doha, Qatar. And he currently is an assistant professor in the Department of Geography and GIS at the University of Cincinnati. Diego's expertise include medical and health geography, GIS applications in epidemiology, mathematical modeling of infectious diseases. And today, Diego will be presenting on the epidemiological and geospatial profile of the prescription opioid crisis. So thank you, Diego, for sharing your research with us today, and I will hand it over to you.
Okay, great. Thank you very much. Thank you for the nice introduction, and thank you for inviting me to give this talk. And thank you all for being in the talk. So let me share my screen. So as Adam mentioned, today I will talk about the epidemiological and geospatial profile of the opioid crisis in the United States. But before I start talking about this topic, I wanted to give a brief introduction about the main focus of my research, which is epidemiology of infectious diseases, particularly the study of the spatial epidemiology of infections like HIV in Africa, tuberculosis in India, hepatitis C virus in Egypt, some vector-borne diseases in Latin America, but also in Africa. But when I moved to Cincinnati a few years ago, in 2016, I started hearing a lot about this situation, this public health challenge about the opioids crisis. So it was all in the news. Something that attracted my attention was the use of the definition of epidemic. So again, for me as an infectious disease epidemiology, this definition of epidemic was kind of strange using for this opioids crisis. So again, they were calling it as an opioid epidemic, and I really wanted to understand why it was calling an epidemic. So I decided to look into the numbers and try to understand a little bit more about this public health problem. And what I found is that definitely we have a constant increase in the number of cases over time, which is very common in different epidemics. For example, since 2000, the annual number of drug overdose deaths was quadrupled, and it has increased from 17,000 in 2000 to more than 70,000 in 2017. So approximately more than 130 patients die from these overdose prescription opioids each year. So you can see that we are facing, or the numbers are saying that we are facing this important crisis. But the interesting part that I also found is that, for example, early in the 90s, the problem was not concentrated here in the US, but you can see the temporal evolution of this public health challenge, and then how these crises start being concentrated in the US. For example, we see that now the opioid-related death rate is about 21 deaths per 100,000 people in 2017, which is the highest worldwide. So of course, this public health crisis is affecting the mortality rate for the entire population. And if we compare the mortality rate what's happening here in the US with other countries, particularly developed countries, we're going to see a different pattern in which the mortality rate is actually increasing and in other countries is declining. For example, the mortality rate here in the country has gone up 3 years in a row from 2014 to 2017, which again is a unique situation that only has seen in very particular time points or time situation, like for example in the World War One, and also in different pandemics, like for example the influenza pandemic that happened 100 years ago, and most probably now that we're experiencing this new pandemic with COVID-19, we're going to see these kind of impacts in the mortality rate. But also if we focus our attention in a very particular vulnerable population, the non-Hispanic white males here in the US. I will talk more about this vulnerable population later, but just to compare this population, the mortality rate in this population, and then compare with our the mortality rate in other countries, you're going to see that the mortality rate is actually increasing a bit in this population compared to the decline of the mortality rate in other countries. So just to give a general picture of how the epidemic look like, you can see that is increasing over time, and it kind of like resembles an exponential growth, which is the kind of behaviors or natural dynamics that we see in emerging epidemics. Like for example, let's give an example of COVID-19, which we see this exponential growth in the early phase of the epidemic. So it looks like we are in this growing phase of the opioids overdose epidemic. Something that also I found very interesting was the regional differences of this epidemic. So actually, at the beginning of the epidemic, there was not too much difference, and the epidemic was kind of similar in different regions in the country. But then after 2008, what we are seeing is a fast increase of the epidemic in the northeast and also the Midwest region of the country. And then you can see that in the west part of the country, the epidemic kind of like stabilized with a slow increase. So that's why all these data are suggesting that we're definitely experiencing a big public health challenge with the opioid overdose. And then what it has been proposed is that this crisis is becoming a national public health emergency, and it's a public health priority now. So that's why many prevention interventions and treatment interventions have been implemented trying to control this epidemic. And one of the interesting interventions that have been proposed was discussed in this report, what I found very interesting. It was published in 2018 by the CDC. It is called Evidence-Based Strategies for Preventing Opioid Overdose. So what I found very interesting is that in this report, they propose a strategy that has been successful for controlling other epidemics, particularly the HIV epidemic in Africa. So the name of this strategy is non-jur epidemic, non-jur response, which was proposed in 2008. The approach of this strategy is mainly the recognition of the fact that there is not a single global epidemic, but what we see is the emergence of many local different epidemics that are being driven by different factors. So basically what they claim is that there is no single HIV epidemic, but a multitude of diverse epidemic. And the most important part is try to identify again what are the drivers of these local epidemics, because most probably the drivers of one local epidemic are not going to be exactly the same drivers for other local epidemic. And that's why it's very important, and they highlight that it will be extremely useful if we understand, we identify who gets infected and how. So I'm going to explain in more detail how the non-epidemic, non-response framework works. So the first thing, or the first step, is trying to identify the agent responsible for the disease. So we are talking about an infectious diseases. This is quite simple. So we know that there's a pathogen, particularly for the HIV epidemic. We know that there is a virus. So we can generate or design control interventions trying to target the virus, like for example, reducing the replication of the virus or even reducing the transmission of the virus. But also the second and maybe most important step in this framework is the identification of the vulnerable population at high risk of infection, and more importantly, trying to identify those factors like socioeconomic, behavioral, and biological factors that characterize this high vulnerable population at high risk of infection. And then also it will be extremely important to identify the location of this high, the geographical location of this high vulnerable population. So if we want to implement this framework for the opioids epidemic, we first need to identify the agent. So generally speaking, of course, we're talking about an opioids epidemic. So opioids in general are going to be the agent, which opioids could be defined as a group of analgesic agents that are commonly used for clinical practice, particularly for controlling pain. So it's basically for pain treatment. And these analgesics are found in the opioid poppy plant. Some prescription opioids are produced from the plant directly, but now we have synthetic opioids that are produced in the lab using the same chemical elements and structure. So as I mentioned before, the prescription opioids are used mainly for pain treatment. We have several medications that included opioids, like for example, hydrocodone, oxycodone, Percocet, morphine, codeine, fentanyl. So for example, if you have a small surgical procedure, most probably you're going to get a opioid prescription for opioids to treat the pain. So most of us have been exposed to this kind of prescription opioids. But also we have illicit opioids like, for example, heroin, and maintenance medications like methadone. So actually, prescription opioids have been identified as the potential agent driving this epidemic. And one of the reasons of that is the strong correlation between the increase in the prescription of opioids over time. So you can see the temporal correlation in between opioid sales, and also how it correlates with the mortality rate linked to opioids overdose. So again, more evidence suggests this big increase in the sale of opioids. For example, by 2001, we have about $4 billion in sales of opioids. And then by 2012, we have an increase of more than 100% to $8 billion. The same prescriptions have been increasing steadily over time. So for example, in 2001, we have about 18 million of prescriptions, including opioids, but by 2012, we have more than 240 million prescriptions. Also, there is some sort of a spatial correlation that suggests this link between prescription opioids and the mortality rate. You can see that the states with highest number of prescriptions for opioids are also states that are suffering the highest mortality rate linked to opioids overdose. So that's why, again, prescription opioids have been identified as the potential driver of this epidemic, and most of the interventions have been focusing in controlling and targeting the agent, these prescription opioids, by reducing the risk of being exposed to prescription opioids. So again, that's why most of the interventions have been focusing restricting the drug availability, including this regulation to prescription opioids to reduce the number of prescription of opioids, but also efforts to restrict the flow of illicit opioids and increasing the access of a medication that is called naloxone. So just an example that happened just a few days ago about this kind of intervention that have been implemented about the regulation of prescription opioids. Maybe you hear about this new, the Purdue Pharma, which reached this $8 billion settlement about the oxycodone that was linked to the increase of opioid overdoses. And that's why actually oxycodone is, of course, out of the market now. So as I mentioned before, naloxone, this medication, has also been one of the main strategies for controlling this epidemic, but this is more like a reactive intervention. So naloxone is a medication that is indicated for the complete or partial reversal of opioid depression, including respiratory depression induced by natural and synthetic opioids. So basically, naloxone is applied to someone that is already in an overdose episode. So it's applied using this nasal spray, and the way that it works is when a person is experiencing an overdose, there is a saturation in the receptors in the brain by the opioids, and then the brain stops functioning normally. One of the results is, like, for example, the person stops breathing. So when naloxone is applied, what it's going to do is it's going to release the opioids in the receptors. So basically, the brain is going to start having a normal functioning, and the person starts breathing again. Naloxone is a very powerful and has been very successful medication, but again, this is only when a person is experiencing an overdose epidemic. So all these interventions have shown some mild positive results. So we can see, like, for example, by 2018 compared to 2017, the mortality rate has declined a bit, which again is showing some positive results from these interventions. But unfortunately, some preliminary data for 2019 is showing this rebound of the epidemic. And again, the epidemic is growing again. So why these like kind of like a negative results? Why the different control interventions that we have implemented for controlling this opioid overdose had not been completely successful, and we have just this partial success. And one of the potential problems with this approach is the common idea or the common perception that addiction doesn't discriminate, and that everyone has exactly the same risk of this epidemic. So basically, what I'm trying to say is that the underlying physiological processes linked to addiction may not discriminate, but most probably several socioeconomic and environmental factors that expose individuals and communities to increased risk of substance abuse are not spatially random. So basically, again, there are some factors that are increasing the risk of opioid overdose, and particularly those factors are not spatially random. They have some spatial variation. So it's actually, this is one of the things that are highlighted in the non-epidemic, non-response approach that again was very successful for HIV, because in the HIV field we recognize that not everybody is at the same risk, that there are factors that increases the risk of infection. So again, it's very important to identify those factors for this vulnerable population. So basically, in this approach, what they claim is that it is very important to generate a clear understanding of the causes and characteristics of the local public health problem. And then that's why it's very important to really identify who is at risk of fatal overdose, or who is at risk of this epidemic, how that risk is constructed. So basically, what are the risk factors that are playing a key role in this epidemic, and then use this information to generate the most efficient strategies to control the epidemic. So basically, again, just going back to HIV, the agent has been identified. There is a lot of control interventions in trying to control the agent, but again, it has been a key element, the identification of this vulnerable population and the location of this vulnerable population. But for the opioids epidemic, we have focused too much in the agent, but we don't have a really good understanding about who is at risk and where this vulnerable population located. So that's why there are two key questions that we need to answer in order to have a better understanding about this epidemic. The first one is everybody at the same risk of opioid substance abuse, and also where are the vulnerable population at high risk of opioid substance abuse located. So that's why we started working in this project, in this study, to answer these two questions. But we started focusing in Ohio, here in Ohio. We use so for this study, we use data from the Ohio Department of Health for death caused by opioid overdose from 2010 to 2017. And the aim of this study was to analyze the spatial-temporal dynamics of the opioid overdose epidemic here in Ohio. So we have like three specific objectives in this study. The first one was to identify the demographic groups in Ohio that are at high risks of overdose deaths, but also to identify the geographic areas in Ohio where the burden of the overdose mortality is concentrated, and also study the temporal trend of the opioid epidemic here in Ohio. Why Ohio? First, as I mentioned before, there is some spatial variation of the epidemic in the country. So again, not all parts of the country are experiencing the same intensity of the epidemic. You can actually see some states that have a decline in the mortality rate, but then there are some other countries where the mortality rate is increasing, and actually Ohio is one of those states. Also, the data suggests that Ohio is the state with the second highest mortality rate linked with opioid overdose. And also you can see that the epidemic is growing a much faster pace here in Ohio if we compare with the national level. So now some general results analyzing the data again from Ohio. You can see this exponential growth of the epidemic from 2010 to 2017. This is actually what we estimated is that the opioid overdose mortality rate increased from about 10 cases per 100,000 people to more than 57 cases per 100,000 people in 2017. So a big increase. But again, as I mentioned before, one of the ideas is try to identify this vulnerable population, these vulnerable groups that could be defined by, for example, race or gender of age. So we use all this demographic information for identification of these vulnerable populations. So what we saw is that white males are the individuals experiencing the highest mortality rate linked to opioid overdose here in Ohio. But an interesting result was that we observed that Black males are actually is actually the group that is experiencing the fastest growth of the epidemic. So, for example, and particularly in this group, what we saw is that Black males aged 35 to 39 are experiencing about 100 deaths per 100,000 people in 2017 compared to the 57 cases per 100,000 people in the total population. So it's almost twice the mortality rate in this particular group. So we are now doing a similar analysis using data from the entire country, but this is some preliminary analysis. We do exactly the same thing, and the interesting part is that we found exactly the same pattern. So what males are experiencing the highest mortality rate, but again, Black males are experiencing the fastest growth rate of the epidemic. So now the second part of the analysis, remember, we want to identify these locations where the burden of the deaths are concentrated. So we wanted to identify these cluster of hotspots of overdose deaths. So we use clustering analysis with a method that is called scan statistics, which basically is able to identify these geographic locations where the number of opioid overdose deaths was higher than expected if we assume a random spatial distribution of the deaths. We also generate a spatial and a spatio-temporal relative risk estimation maps using Bayesian methods. So the results from this analysis again here in Ohio, one of the results that I want to highlight is that even that Ohio is experiencing again a high burden of the epidemic, not everybody is at the same rate, same risk even within the state. So you can see areas where the risk of opioid overdose is quite low, and then you can see areas where the burden of the problem is concentrated. So we identified 12 geographical hotspots. In this hotspot, we estimate that about 20% of the population of Ohio reside, but about 40% of the total deaths were happening here within these clusters. So we estimate that the mortality rate by opioid overdose within the cluster was almost 3 times higher compared to what is happening outside the hotspots. Another interesting result was to analyze changes in the risk of the opioid overdose over time. And what we found is that the risk of opioid overdose death is actually increasing between the hotspots. So we estimate that the risk is increasing about 10% from 2010 to 2017 within the hotspots. But the risk of opioid overdose is actually declining outside the hotspot. So we estimate about 3% decline of the risk outside the hotspots. So this result is actually very interesting because we have seen that pattern in other epidemics, particularly in infectious disease epidemics. So it's very interesting to see that we have completely different systems, but the pattern is present in these different epidemics. So I just wanted to show as an example the HIV epidemic. So we conducted this analysis a few years ago for the HIV epidemic in Zimbabwe and in Malawi, and we observed exactly the same pattern. The HIV prevalence is maintained constant and actually is increasing between the hotspots, but the HIV prevalence is declining outside the hotspots. So this is indicated that maybe epidemics tend to disperse and be more homogeneous early in an early phase, and then in a more mature phase, the epidemic start contracting in the high burden areas. And no matter the systems, if we're talking about an infectious disease, we are talking about something like opioids overdose. So just want to show you or illustrate how the temporal and spatial evolution of the epidemic here in Ohio to illustrate the emergence of the hotspot and then how these hotspots had been established in different high burden areas. Particularly in urban areas in Ohio. So you can see here the emergence of these hotspots and then how the epidemic is growing exponentially over time. And again, the epidemic start emerging in those hotspots, establishing those hotspots, but we have some dispersion of different cases outside the hotspots. Okay, so now let's focus in only the temporal dynamics of the epidemic, because what we wanted to see if that we wanted to identify specific time points in which the growth rate of the epidemic has changed. So to do that, we conducted an interrupted time series analysis, which basically is able to identify these or detect these changes in the growth rate. And then the analysis assume that those changes are produced by disturbances caused by external event. And those external events could produce positive effect in the growth rate, means that the growth rate is going to increase, or it can actually produce a negative effect in which the growth rate could change, it could decline. So using this analysis, what we found is 3 points in time in which the growth rate of the opioids overdose epidemic in Ohio has changed. So we found one negative effect and then two positive effects. So the first time point with a negative effect was detected in 2011. Most probably this negative effect is indicating some good or positive effect from the intervention, which was able to reduce a bit the growth rate of the epidemic. But then we identify, as I mentioned before, these two positive effects in which the growth rate actually increased, and the one with the highest impact was detected in 2013, in which we estimated that the growth rate increased by 21%. So this result could be actually linked with, it is well known in the opioid overdose epidemic that is called the triple wave epidemic. So in this dynamics, it has been claimed that the opioid overdose epidemic has experienced these waves, these three waves, in which the wave one was a wave in which the dynamics or the epidemic was driven by prescription opioids. So this wave started in the early 90s and then peaked in 2011, which is the moment that we have these negative effects. Most probably, as I mentioned before, all these interventions that were taking place to the regulation of the prescription opioids. So for the second wave, we now have a different substance leading or driving the epidemic. So now we have heroin, which was the main substance linked to overdoses deaths. So these waves start taking place in 2011, and then the last or the third wave, which is the wave that we are currently experiencing, is now being led by synthetic opioids, particularly fentanyl. So again, you can actually see these three different waves spatially. So again, this is preliminary results that we are generating using data from the entire country. So now what we did here was to identify spatiotemporal clusters, not just spatial, but also spatiotemporal clusters. So with this analysis, we can detect the year or the moment in which the cluster emerged, and also we can see if the cluster has been stable over time. So we're interested in clusters that are having stable over time and not just clusters that appear and disappear. So with this analysis, we identify the emergence, or basically we identify two time periods in the emergence of the hotspots. The first time period is those hotspots emerging in 2010 and 2011, and most of those hotspots were located in the western part of the country. And then the second time period in which new hotspots were emerging was in 2014 and 2015. And again, most of these hotspots were located now in the eastern part of the country. And also something very interesting about these hotspots is the substances that are more commonly linked within the hotspots. So for example, for the hotspots emerging early in 2010 and 2011, the main substance linked to the overdoses was actually prescription opioids, which remember was linked or was the reason, the main driver of the first wave. So these hotspots again were emerging in 2010, 2011. And then for the second time period, the hotspots that were emerging later in 2014 and 2015, actually the substance leading the mortality rate was heroin. So we estimate that about 34% of the deaths were related to this substance. So again, we can see how these differences in the substances that have been included in the epidemic have been influenced not only the spatial distribution of the epidemic, but even is influencing the changes in the demography of the epidemic. Because, for example, prescription opioids have been steadily increasing over time, but now you can see how heroin, but particularly synthetic opioids, have been increasing substantially very recently. That's why it could be the potential reason about why Black males are now the vulnerable population for this epidemic. So most probably early in the epidemic, prescription opioids were not available, or were not oftenly available for the Black population, but now synthetic opioids are actually more available and cheaper than prescription opioids, and for that reason, most probably this could be the reason or the link between the rise of synthetic opioids as the main driver of the epidemic, but also the increase in the mortality rate in the Black population. And we can even see that spatially as well. So now we were interested in generating clusters, but by race. So the clusters illustrated in green are clusters only for the white population, and the clusters illustrated in blue are the clusters for the Black population. So you can see that, for example, those clusters that emerged in 2014 are located in clusters with most of the clusters of the Black male population are located. So most probably those clusters have been driven by the synthetic opioids, but also by the increase of the mortality rate in the Black population. Okay, so let's summarize a bit all these results that we are obtained so far. First, and what I want to highlight is, like, for example, um, in HIV, what we have, even though of course we're talking about a very complex epidemic, we have a one single agent, a virus. But for the opioids overdose epidemic, I want to highlight that we are not facing an epidemic with one single agent, but we're facing an epidemic in which many agents have been introduced in the epidemic over time. So that's why maybe this approach of targeting the agent, targeting the opioids is not the most efficient one, because we have been focusing a lot on, for example, prescription opioids. But the problem is that we have this dynamic multi-agent system in which many elements have been introduced in the epidemic, and then many substances have been influenced the dynamic of the epidemic over time. Like, for example, we started with the prescription opioids, then we moved, the prescription opioids were kind of like regulated, but then we moved to the heroin, and finally we are facing this problem with fentanyl. And maybe we regulate fentanyl, what else is going to come next? So that's why I like this quote, and that was included in a commentary published in Nature in 2019 by Judith Feinberg. So she said, unless attention turns to what leads the addiction and overdose, treatment will always be out of date. So maybe it's highlighting how important is trying to understand the factors, particularly the socioeconomic, the demographic factors that are driving this epidemic. So again, it will be very important now that understanding that we have this complexity introduced by this dynamic multi-agent system that is producing this challenge for controlling the epidemic. We maybe need to focus more in the second phase or in the second part of the non-jure epidemic, non-jure response framework that, as I mentioned before, was very successful for HIV, which is the identification of who is at risk and where are these people located. So that's why we are trying to contribute with that information, trying to identify those demographic groups that are more at risk, and also the high burden of the epidemic, of the problem. But of course, we need to more work on this topic, because again, we're talking about a very complex system with a lot of different determinants coming from different from different factors, like, for example, socioeconomic and environmental factors. Of course, genetic and biology is important as well, but we have health behaviors, healthcare, the physical environment. So all these factors are going to be integrated and are going to influence the epidemic. And just to show you how challenging it is to identify those factors, I want to illustrate this with a problem. Like, for example, for drug use disorder, this is the distribution that we have for this problem. But if you look to another substance, like for example, alcohol use disorder, you're going to have a quite different distribution, which means again that the factors that are influencing the distribution of those public health problems are not exactly the same. And again, more complexity is introduced in the system because we have different elements and let's say different scales that are going to introduce different factors in the epidemic. Like for example, factors are introduced by the individual scale, but also by the interpersonal, the institutional, community, and actually by the society. So all these kind of different layers are going to introduce different factors and again are going to increase the complexity of this epidemic. And that's why now many groups, many research groups are trying to focus in this problem and trying to identify these social factors driving the epidemic. For example, in this study published in 2018, they identified that economic distress and family dissolution were linked with higher mortality rate by overdose, but presence of religious establishment were linked with actually low mortality rate for those groups. We can also see that activity is influencing the outcome of the epidemic. Like for example, we see that mining activities and service activities increases the risk of mortality, but again the influence is not exactly the same. So we can identify different influences depending on if we are talking about rural or if we are talking about urban areas. So now we're also exploring other social determinants of addiction, particularly comorbidities, especially mental health. So for example, just want to show you some preliminary analysis that we're doing. So this is a map of drug poisoning, and this is a map of mental health represented as a number of mentally unhealthy days. So you can see some geographical correlation between these two factors. And when we run, like for example, a clustering analysis, you can see a cluster of mentally unhealthy days located very similar to, in a very similar area, that's a cluster for drug poisoning mortality rate. We actually, again, just analyzing the data, some preliminary results exploring this link between mental health and the opioids overdose. We conducted this analysis using data from the entire country and controlling for some socioeconomic factors. We estimate that again, mental health was linked to an increase of the mortality rate. Like for example, we estimate that an additional average day of mental distress was linked with an increase of the risk of substance use disorder related mortality by 39%. Okay, so just to move a little bit more general, I feel like this is what we are doing here in the country, where the efforts that we are doing for understanding the epidemic here in the country are going to be very relevant, because now we are talking about the potential of this epidemic becoming a pandemic, because this situation is now not only facing by the United States, but now we are seeing that this problem, this epidemic is emerging in other countries. So that's why the idea about this potential spread of the epidemic to other countries is real. And even the data are suggesting this. You can see that for other drugs, the mortality rate has been quite stable over time, but you can see this exponential increase of the mortality rate linked to opioids, a very similar exponential behavior that we saw for the country. And even many countries are talking about this problem. They have been detecting this emerging problem, like for example, in the UK, also in Denmark, in Canada. And even more interesting, in Africa also, there are some countries that start identifying this problem, and maybe we are talking about a hidden epidemic in Africa, particularly in South Africa, where they have been identified this problem of codeine dependence. And that's why we are now also analyzing some data from this country, from South Africa. So where I'm showing here is, or I'm illustrating here is clusters of high frequency of codeine use. So you can see here the cluster in the northern part of the country. Something very interesting because we don't see a correlation with, for example, infectious diseases. So HIV or tuberculosis is mostly concentrated in the southern part of the country, particularly in this region here in KwaZulu-Natal province. So we also were exploring the link, the potential link between mental health and the codeine substance use and abuse. And what we identify was that, or we estimate that individuals that are located within these clusters of codeine actually have a higher odds of having depression. So it was a link between the codeine use or ecological link better, between codeine use and depression. Okay, just to finalize some important remarks that I want to provide for this presentation. So the first one is, and the one that I want to stress is that, again, even within the country, even within US, we are not experiencing an homogeneous and a single epidemic. What we see is a lot of spatial variation, and then we have different local epidemics with different intensities, and most probably what we are seeing is that factors that are driving these local epidemics are not exactly the same by the different hotspots where we identify. So that's why it's very important to try to work more in the identification of these factors. Also, we identify a particular demographic group that is experiencing the highest burden of the epidemic, the white males aged 30 to 34. So for example, we estimate that about 34% of the total deaths in this group are actually linked with opioid overdose. So it's this quite high numbers for this particular group. But another important result is that even though the white male population is the one experiencing the highest mortality rate, it's important to look at the black male population, because now there is this emergence of the epidemic in this particular population. And another point that I want to highlight is this complexity of the epidemic produced by different substances. So again, we're not talking about, like, for example, an epidemic leading by prescription opiates. We're talking about an epidemic that, again, it has been fueled by different substances over time. Just to finalize, again, I want to highlight that individual and community level risk factors are not homogeneously distributed across different demographic groups, which are generating a series of sub-epidemics emerging at different times and locations within the country. And again, a good understanding of these dynamics could give us, could provide a much better tools for a much better control, for the much better design of control interventions. And then by ignoring the underlying drivers of drug consumption, current interventions might not be the most efficient, changing the trajectory of the epidemic. And we propose that micro-targeting strategies based on understanding of the spatial structure and this multifactorial nature of the addiction epidemic will facilitate that will be more efficient in the design of targeted integrated prevention therapies for the early identification of diagnosis of this vulnerable population. One of the studies, particularly for the Ohio study, is already published in the journal Scientific Reports. If you wanna look and get more information about this study, and just wanna thank the Center for Disease Control and Prevention for funding this work, and also, of course, I wanna thank all the people that were involved in this study, particularly Adam, where we have been working for many years, and maybe this project is one of the most interesting projects that we have been working together. But also I want to thank Neil McIntosh, that he is working in the College of Pharmacy, Anna Incapie, and also I want to thank my grad students, Andres and Jinjin. And thank you for attending the talk, and I'm happy to take any questions. Thank you.
All right. Thank you so much, Diego. That was a wonderful talk.
Thank you.
Opening it up to questions. So I'm not an expert in I'll do my best here. So this is a question that reads, is there any analysis of employment status that provides some insight to the incidence of depression correlated with overdose?
Is that what is again, because I didn't get the question.
Sure thing. Is there any analysis of employment status
Employment.
that
Okay.
provides some insight to the incidence of depression? So I guess the question, and perhaps the person who typed it, because I'm not quite understanding it either, is looking at, is there a correlation between employment status
Yes.
and depression? I think that might be what they're getting.
Yeah, maybe controlling for unemployment. For the depression was linked for the study in South Africa. We didn't have information about unemployment. We have other socioeconomic factors included in the analysis, but for mental health, unemployment was included for the mental health and link between mental health and the opioid overdose here in the U.S. We definitely have information about unemployment. And also we have information about about well, other socioeconomic factors. We didn't find any link between unemployment and the mortality rate, which was something interesting. We found that, for example, poverty was linked, education was linked. Let me think which one else was linked. The other one that was interesting was physical disability, which again could be linked to pain treatment. And this has been discussed a lot because, of course, if there are injuries, particularly work injuries, people are going to be treated with prescription opioids, and that's one of the issues that has been highlighted about this epidemic and how we treat pain, and particularly when there are some injuries at work. So it has been linked in this study.
Great. So looking here at more question and answers. Well, it's just a question that reads housing question mark. Perhaps Jill, you can be a bit more specific. So are you thinking about the homeless population? I'm not quite sure what you mean by that.
Yeah, I feel like maybe questions are related about all these socioeconomic factors, which I think they're extremely important. It's
Right.
very challenging. It's very challenging. I hope it's very challenging to get all this kind of information, because where we have is like these information that are coming at different scales. Like, for example, we just get we don't get individual level factors, for example. So we have to have a kind of like a multi-level analysis, because some of the factors come at county level or even a state level. So this is a bit challenging. And again, as I mentioned before, this is a preliminary analysis. We're still trying to gather all this socioeconomic and demographic information. But again, I feel like those factors, like homeless, unemployment, even age, as we highlight here, are going to be extremely important. And the other thing, that the other challenge is that, for example, some factors are affecting a particular age group, and some other factors are affecting another particular age group. So this is some of the challenges that we have, that not all the factors are being influencing the same age groups, and even the race, and even the gender. Because, for example, something very interesting that we found is that females get more prescriptions for opioids than males, but are actually males the ones that are getting addicted. And particularly in this, we were surprised about finding this big impact of the epidemic in this male population 30 to 39, because it's like, what is happening to these people, to this particular population, which could be like the moment of distress, like responsibilities. We were just discussing about what potential reasons are driving this particular population, which again have not been the most exposed to the prescriptions, because the prescriptions are more often in women, in females, but actually they are the ones who are getting influenced or really hit by the epidemic.
Yeah, great. So we have another question. A couple of questions here. Okay. So this is actually a comment. The geographic data is fascinating, really helps to understand that not everyone is at the same risk.
Yeah, I completely totally agree.
Were you expecting that ahead of time, or did you not have?
No, no. Like when I got contact, it was actually a project from the College of Pharmacy here in the university that they contacted me about like this data with geospatial information, and they say, "Are you interested just to explore?" And I said, "Yeah, sure, why not? Just to make some exploratory analysis." And then like the pattern was so strong that it's fascinating, because again we're controlling for the population density. So the clusters what we are identifying is not just population density, we're controlling for that. So it's like another interesting part. I didn't show this analysis because now we are doing these urban rural areas, is for example the perception that this problem is a rural problem which is not. It's really, or not really, but you can see is quite strong in urban population, which is like, and that's why, like for example, some factors don't get quite well in the analysis because so we don't know. We need to think. We need to think more about how to analyze it, because for example that again. So yeah, going back to thinking about all these variation, I was not expecting that. And that's why I got super excited, because it's like, okay, if you can identify so clearly this variation, it means that maybe we can do a better job trying to identify the drivers of the epidemic, because something definitely is boosting the epidemic there. So we should focus there and see what's going on.
Yeah. And we have this question. The map of the drug disorder for the whole world shows distinct spatial variations in different countries. Do you think the culture, religion, and health system contribute to the spatial variations?
That's a great question. That's a fantastic question. Yeah, I actually have never thought about, like look at the map and start thinking like why this is happening. Like for example, when I started working with the data with South Africa, I was super surprised. I was looking for literature about this problem of codeine in South Africa, and it's very common, and it seems to be a quite big problem, but nobody talks too much about it. And it's like, huh, why not? And again, it has a spatial structure. We have no idea what's going on, what is driving it, because it has no correlation with HIV, no correlation with tuberculosis. Apparently, has some more correlation with chronic diseases, because diabetes is very prevalent in the area where we have these clusters. But I have never like look in detail the map from the entire world and think, oh, why? Like that's a great question, and something
Sure.
that could be interesting to explore at global, like the global situation and scenario. And most probably, yeah, absolutely. If you think there is some cultural issue or cultural characteristics that prevent or facilitate maybe the spread of the epidemic, as many other epidemics that we see, religious as well, and even economic factors that could be influencing that distribution of the epidemic globally. But that's a great question. I will look in more detail about it.
Sure. So we have the question. Oh, this is great. What made you interested in the opioid epidemic?
So as I mentioned before, here in Ohio is October before COVID-19 because now it's just a lot about COVID-19. So a few years ago, it was like people were really interested about this problem, and it's definitely a big problem here, West Virginia and also in Kentucky. So you have these three states in which the problem is quite an important public health problem. And then I was attending several talks, and one of the things is that I started being interested in mental health, which again could be linked to this issue. And finally, I got invited to analyze this data. And when I found spatial structure of the problem, I thought like, oh, this is something that we should explore in more detail and look of this epidemic in more detail. Also, the way that it has been or the interventions that have been implemented, I find it very interesting because again, it's like this traditional way of trying to control the problem with regulating the substances, which is the common way that we treat or that we control drug addiction and drug problems. But again, I'm not very, or I don't agree too much with this approach. I feel like we should work more in the underlying situation, underlying factors that are boosting this problem, and not just focusing the substance, but focusing in the real problems that are facilitating this public health problem.
Yeah, great. I think we're just at time. If there are any other questions from the audience, last minute burning questions, please type them in right now. While you're doing that typing, I will ask you, Diego, because we do have a lot of graduate students in attendance today. And I know you've been doing spatial epidemiology research for many years now. So can you just briefly tell them the types of software that you use to generate the slides that you presented today?
The slides.
Yeah, the slides, the results that you presented.
Okay. Well, we mostly use ArcGIS. I will say is a very powerful software. The only issue is like it's not free. Sometimes it's quite expensive, but they are really, I mean, it's really powerful, particularly for visualization more than for analysis, because actually the statistical analysis are mostly done in R. Also, we use these SAT scan statistics. That is also an open access software, which is extremely useful, extremely powerful, and extremely easy software to use. So ArcGIS, R, SATScan. Let me think which. I think that's the three main software that we are using. I mean, all the analysis that we do can be done in R, even the visualizations. But I still feel that R is great for, again, statistical analysis. But the maps, the quality of the maps in ArcGIS are just fantastic. And sometimes good quality in maps is extremely important, particularly when you want to deliver a message. So something, like you have a good map, a very nice map, people get more engaged and they actually understand more what you're trying to say than when you have these maps that the quality is not the best. And also, again, ArcGIS is a bit easier to use than R. And also for storage of spatial data sets is quite simple to use ArcGIS than R. But anyway, R can be used for any kind of analysis that I just presented. And actually SATScan is linked to R, so you can use R just to call SATScan and run the clustering analysis using R. So everything can be done in R, but sometimes ArcGIS is nice for the visualizations.
Yeah, that's great. Thank you. It looks like we have maybe one more comment here. Do you recommend all up-and-coming epidemiologists to become familiar with geospatial profiling?
Absolutely.
So you're going to get a bit of a biased answer from Diego.
But you know what is this is becoming so popular? There are two factors. The first factor is just because I remember, I mean, particularly I'm coming from a developing country. I'm from Colombia. I remember 20 years ago or 15 years ago, when I started working on or started learning this GIS, it was, like getting spatial data was very expensive because you actually need to have a device, a GPS device, and go to the place and get the coordinates and things like that. But now everything comes with spatial information. Your cell phone is collecting spatial data all the time. So most of the data now has a spatial information, and that's why uh, analyzing the data in a spatial, dimension is very important. And the second part is that, again, before computers were not very powerful, so running a spatial analysis in a PC was not very efficient. But now computers are super powerful, so you can run a very sophisticated spatial analysis in your laptop with no problem at all, and that's also facilitating, like the popularity of spatial analysis and making and mapping everything. And the third part is that, again, showing maps is more entertaining and more interesting, and actually deliver a message and deliver information with a map. I feel, at least for me, it's easier. For example, when I go, again, I work a lot on HIV in Africa. When I go there, and if I show the people from the public health department in I don't know, in Zimbabwe, let's say, and I show them tables or equations, they don't care, they don't understand. But when you show them maps and you show them, like, maps are really easy to digest. So when they see maps, for some reason they get engaged, they understand the message. So it's actually a very nice way of delivering your results. So that's why I think is absolutely, as epidemiologist, I feel like it's very effective way for analyzing the data, but also for delivering your results.
Yeah, I completely
Yeah,
myself.
we're the same.
Yeah. So again, thank you so much, Diego, for presenting your
No,
research.
thank you so much for the invitation.
Yeah.
I really
We know
enjoy.
it's relatively late where you're at on a Friday afternoon, so
Oh no, we still have some.
thank you.
No, it was great. Thank you very much for the invitation. It was always nice to talk about these kind of important topics.